Well, good afternoon again, everyone. It's 2:25, and as I promised, I was going to kick into the next session now. I hope you all had the opportunity to at least grab a cup of tea as we kick into the second half of today's Rural Mini Symposium. Our next speaker is Dr. Joe Scott Holmes. Dr. Joe is a medical director of Pinnacle MHN, which looks after 87 practices and 450,000 people across the middle of the North Island. Those are incredible numbers to kick this off. He currently chairs the National Primary Care Clinical Leaders Forum, works as a locum GP, and helps run a general practice in Opotiki. Wow. Joe has been the chairperson of the Rural General Practice Network, the Rural Health Alliance Aotearoa New Zealand, and a board member of the Royal New Zealand College of General Practitioners. He's a specialist in general practice and has a master's degree in medical science. That is an incredible bio to read out, Dr. Joe. The floor is yours.
Thank you very much, Andrew, and thank you for the opportunity to talk this afternoon. What I'm hoping to do today is to share a little bit about what Pinnacle does as a network of general practitioners, as an example of the work that similar general practice networks do to support general practices in every part of New Zealand. And I hope that you would agree with me that it's important to have healthy communities, and general practice is an essential part of healthy communities across rural New Zealand, without which we wouldn't be here today. I'm going to share some of the impact of the COVID pandemic on the way general practice has been working, and give some examples of the way that technology is being utilized in general practice and what we've learned from implementing those projects, and end with a call to action from members of TUANZ. So next slide, please. The ko mo vamo te maunga, ko mezi te awa, no Ngāti Pākehā aho ko ohopi toku tūranga waiwai. He Pinnacle Nedlands Health Network Medical Director aho Mahiana, ko Joe Scott Jones toku inga. I don't have any conflicts of interest, and just again, thank you very much to Craig for inviting me along. Hopefully what we'll do today, it was really interesting listening to the Minister talking about setting standards and investing in improving standards of broadband access, and to hear from Andrew, Claire and Angela about the real challenges that people have in accessing high quality broadband, and from Claire and Angela, that little bit of vision about what would life be like if we really did have good access. What I'm hoping today is to show some of the things that we've done to improve digital infrastructure, and then some of the things that are then flowing on from that investment. So firstly, Pinnacle, as was said, we look after 450,000 people across the North Island of New Zealand. We're one of the largest networks in terms of our reach into rural communities. 29% of our patients live in rural communities. And there are just a few examples there of the amount of work that those 270 odd full-time equivalent GPs and nurses have done across across those practices over the year 2020 to 2021. None of this happens in isolation, of course, and prior to the pandemic, we're very aware of the impact of the lack of investment in training and in developing primary care that has happened over many years across different governments of different colours. The Pinnacle has been working on a rural strategy over that time, and our key aim really was to make it easy for people to stay close to home when they were needing access to healthcare. And of course, rural connectivity was a significant part of that. Back in 2018, 2019, we made the choice to invest quite heavily in improving the connectivity of our rural practices, so that every practice had at least 30 megabytes download speed. We also started initiatives to reach specialists into rural communities. One example being a psychiatrist who we employ, who can provide direct patient care, but also support our practices in the care of people with mental health challenges. Many of you will have on your phones a portal which allows you access to your GP records, to appointments, to results, and to an online communication with your general practitioner. If you don't, then I would encourage you to ask your general practice to open up access to a portal for you. It's a brilliant way of improving your ability to stay at home and yet still get access to healthcare. The other thing that we've been looking at to ensure that people can stay close to home and I'll talk a little bit in detail about these later on, about improving point of care testing and also telemonitoring and point of care ultrasound in general practice. I'll give some examples of those. They're all reliant on us having excellent access to the internet. So the impact of the pandemic, as you and I full know, was back in March last year, February last year, that we had our first cases. It's a deadly virus. It's not inappropriate to say that. 20% of people who are being exposed to SARS-CoV-2 were getting hospitalized. About half of those are needing ICU. In different countries, between 2 and 10% of people were dying. And it was the 21st of March 2020. We had a phone call from Brian Betty, the medical director of the College of GPs, who said that because there was increasing evidence that one of the sites of transmission for COVID in the communities, particularly in Italy, was healthcare centres, that they were asking us to stop people coming in for in-person consultations in practices as far as was humanly possible. They anticipated that we would reduce the number of people coming through our doors by about 70%. What then happened, so Craig, we're on to the slide with the colourful graph. So that's the workforce, that's the timeline for the pandemic, and that's the, so by the 23rd of March, 2 days later, practices that had set up a phone first system, which many of you will have experienced, and we'd expanded what we called red streaming of patients, so that anybody with any sort of respiratory symptom had a different pathway through the general practice, and we'd started working on implementing video consultations. And that key question, and it's the question that we're still encouraged to ask ourselves today, is what extra value do we provide to this patient by bringing them in for an in-person consultation? What you see in the graph is the number of telephone consultations that our practices were recording, and where it peaks is at the March 2020. What I find really interesting about this graph is that after the lockdown had settled and then through the rest of the year, there's been a significant step up in the number of telephone consultations which are happening across general practice. And then this most recent peak is the beginning of this most recent lockdown. So next slide, please, Craig. What you see here, and I know this is really complicated, but just concentrate on the green and the pink colors, and you'll see that where the arrow hits, which is in March 2020, there's a shift from the green represents 50 to 60% of patients who are ringing up and asking for a same-day consultation being given a same-day consultation. And then after this, the impact of the shift in the way that we delivered our services was that 50 to 60% of consultations are resolved with phone advice alone after the implementation of the lockdown. And again, what I find really fascinating here is that that's then continued through the whole of the year. There's been a significant shift in the way that our practices are serving our population to a much more of an online experience, which again, I'm sure that most of you will have experienced. Next slide, please, Craig. So here, the graph at the bottom shows what's changed since 2018 in terms of the inbound portal activity for our practices. And what I just want to remind you when I'm sort of looking at these figures is what I said about workforce previously, that the GP workforce has been under significant challenge, both our nurses and our GPs. If we look at what's happened with our urban workforce, it stayed pretty steady in terms of the full-time equivalent that's available to service patients. If we look at what's happened to our rural workforce, what we've seen is a steady reduction in the full-time equivalent hours available from general practice, and a slight increase in the number of hours that are equivalent for our nurses. So over this period of time. So if we look at on the top left-hand corner, what's happened with consultation rates from 2019 through to 2021, our general practices have seen a significant increase in the number of consultations that are happening for GPs and for nurses. In the bottom graph between 2019 and 2021, you'll see a huge increase in the number of e-referrals that are being made. So patients that are being seen are being referred on, needing further care at a much higher rate. This reflects the level of assessment and workload that's impacting on general practices. At the same time, in the second column, you'll see in 2019, 130,000 ED presentations, and 2021, 117,000 ED presentations. So for our enrolled population, we're seeing a reduction in the number of presentations to our emergency services in hospitals. We would put that down partly to the next column that you'll see, where in 2019 there are 12,000 primary options services, and then a significant increase to 2021. Now, this primary options includes extra services that are provided in general practice that help to keep people away from hospitals. So that might be treatment of a child who's dehydrated, or an extended intervention with somebody with asthma. The reason why there's such a significant uptake in upswing in primary options is because it also includes our services around COVID. But what the picture that I'm painting here is that your general practice service has probably had some very significant challenges in terms of its workforce, but has had to shift to largely an online phone-first service, still providing very significant in-person consultations for what it needs to be done in person, and is having a significant impact on the quality of care, I would posit, because fewer people are needing to go through to ED. Next slide, please, Craig. I want to talk specifically about a couple of the technology challenges that we've embraced. One is around point-of-care ultrasound. As a network, we recognized that there was a significant opportunity to bring ultrasound, a different way of looking inside the body, what is seen in some countries as the stethoscope of the future, into our rural practices. So again, so that people can stay close to home and improve the quality of the care that people are getting. Since we've trained people up to provide ultrasound and provided handheld ultrasound devices to our rural practices, over 1,000 ultrasounds have been performed. Mostly around pretty common sort of conditions. You know, is there a gallstone here? Isn't there a gallstone here? Does this person have pneumonia? Don't they have pneumonia? Is this lump solid or is it cystic? Which has then sort of implications for us. And in terms of the management. Those images are collated and uploaded into an online library, which then supports peer group review. So the GP ultrasonographers get together and share the images, talk about them, talk about the cases, and through that improve the quality of the care. But you can see that this relies hugely on really good connectivity from our practices and between our practices. Next slide, Craig. Another initiative is around point of care testing. The device that you see there is an iStat machine, and that allows our practices, our rural practices, to perform a number of near patient testing. In particular, we focused on chest pain. If you present to a general practice with chest pain, it's extremely likely that you're going to be sent through to your local hospital. A big reason for that is so that we can get rapidly get the view of what's called a troponin test, which measures whether there's been damage to the heart muscle. What we found by introducing point-of-care testing into our rural practices is that we've been able to safely reduce the number of referrals through to hospital by 50% for people who present with resolved chest pain. If you actually have chest pain, the quicker you get to hospital, the better. But if you've had chest pain 3 or 4 hours ago and turn up at your general practice, then where previously you would have been sent through to the hospital to have a troponin test, we're now very confident that we can safely, through using a point-of-care test, reduce that unnecessary travel. Some of the issues we have with these machines, as they're distributed across a very wide area, is ensuring the quality assurance and that they get updated. And there is also implications around cost, of course. But again, the quality assurance and updating relies really heavily on having really good access to high quality connectivity. The third thing I'd like to talk about is some telemonitoring and remote monitoring of patients. Now, this is very likely to come significantly to the fore over the next 6 to 12 months as we move into a situation where COVID becomes endemic in our communities, as we open our borders, and there will be low levels of COVID across all of our communities, I would posit. The people with COVID at a mild to moderate level in the community need to be regularly checked. One of the key issues is having a pulse oximetry done to measure the oxygen levels in your blood. And one of the things that we've trialed is having things like pulse oximeters, blood pressure devices, spirometry in general practice in patients' homes, and then having GPs monitoring those from a distance. And what I'd like to do is share some of the learnings from that. from those projects. It's certainly what we learned was that having those telemonitoring opportunities was really valued by patients. The increased people's ideas of self-care. We also know from international studies that at a really large scale, these sorts of projects can reduce unnecessary hospital admissions. The downsides are that they are really quite labor and cost intensive for general practices. It's basically ourselves as a network or our GPs purchasing the equipment, getting the licenses for the use of the equipment and the support. It's not really, these things haven't been supported by the system. And that's partly because the impact on the health system as a whole is unclear in terms of cost, unless it's implemented at massive scale. The next slide, please, Craig. So some of the telehealth issues, the telemonitoring issues that we've discovered through these sorts of projects is that the data that we gather through these devices needs to be linked into our practice management systems. You know, it needs to be it works best when there's a seamless link between the devices and the record system that the patient's records are kept into. It obviously needs people on the other end of the line putting intelligence over the results that they're getting. And unless the system is going to invest in this sort of thing, it's going to come, the way our system works currently, is that this comes at a cost to the practice and a cost to the patient. We did see some changes over time with engagement from the users, as you'd expect with any sort of change management sort of project. You know, people are enthusiastic at the start, and then there's a little bit of a drop off. So we need to sort of maintain the effort and enthusiasm and maintain the support around the delivery of these systems. Next slide, please. So at a practice level, what we learned was that having a pre-assessment of introducing these sorts of things into practices is really, really important, and to identify issues around what we call the red flags. If there are issues around the red flags, then we need to address those. Otherwise, it's likely that engagement with the project is going to drop off. Next slide, please. So things like identifying if there's low staffing levels. So if people aren't there to analyze the tests, aren't there to provide the test on site, then that needs to be addressed before implementation. And we are already a significantly stressed workload. The practices that have engaged in these things have tended to be real enthusiasts. But they have to manage the increased workload and the impact of stress on their staff as well. Clearly, as I've indicated, and the reason why I'm talking to you is that you know, poor internet and poor equipment you know, needs to be addressed, so that you know, an analysis at a practice level of what their internet speeds are, have they been updating their computers, do they have good robust systems? Because if we don't do that, then people start to create sort of workarounds, which just adds more work and less efficiency. A lot of our providers are tech savvy and are really interested, but if we can improve their knowledge around the equipment and how it works, then we find that we get greater engagement. And one of the key things is to identify somebody in the practice who's going to be the telehealth champion. Great, the next slide. And that telehealth champion is absolutely has been absolutely key. They're the person who takes responsibility for providing that education, following through with staff and patients around their engagement, They can troubleshoot the equipment and, most importantly, work well with the partners, the technology partners that are helping to deliver on the system. Identifying that champion and encouraging and supporting them really helps to implement change like this. The next slide, please. Another key thing is to have a system which proves its value. So at the start, to think about, well, how am I going to evaluate this? What difference am I actually going to make? And to have a way of either quantitatively measure outcomes, or at the very least qualitatively assess how people's experience, both the provider and the patient's experience of the project. So I'd like to reflect on those learnings and finally ask for your help. As the Telecom Users Association in New Zealand, the people listening to the webinar today, we need primary care providers need your help and support in recognizing what technology can do for them, to plan for the implementation, and we need help with implementation of those services that improve the quality of care that we can provide and keep people close to home in rural communities. I know that our network and other GP networks around the country, I know the Rural GP Network and Rural Alliance, are great vehicles for those conversations. If you've got good ideas, then we'd really like to hear them. The other thing is that, we do know that, as I've indicated, telemonitoring is going to become a very essential service, I think, in the future. If our borders do open, if that does result, as I expect, and a lot of health professionals expect, that COVID becomes endemic in our community, then telemonitoring is going to become a significant service in every general practice, and there are over 1,000 of them across the country. The other thing that we need is help developing systems that can be linked into seamlessly whatever practice management system a practice is using. Currently, there are about 6 players in the practice management system space, and they all work slightly differently, and they all need people to work with them in a slightly different way. So your help in addressing those issues would be really welcome. So thank you, Craig. Thank you for the opportunity to talk about what's happening in general practice. I think it reflects some of the hope for what we can do if we get what the Minister has talked about and significant investment, and if we can address some of the real world problems that my fellow speakers have talked about so far in terms of improving that connectivity. So kia kaha, and thank you very much.
Thank you, Dr. Scott Jones. You had some absolutely fascinating data about how your network has responded to these challenges. Thank you so much for that. And I hope that all of our attendees here have heard that ask for any help and advice around potential solutions that you may be aware of. I think that after all the GPs do for our communities, that this is an opportunity for us to think about what we can do back. Thank you, Doctor.